This is It's Not In Your Head podcast with Dan and Juz. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers. Hey there, welcome to another episode of It's Not In Your Head podcast with Justine Feidelson and Dr. Dan Bates. Hey, Dan.
Morning, Juz. How are you?
Good, good. Today, we are going to get into Dan's back and leg pain algorithm, essentially. This ties into previous episodes that we've done on nociceptive pain. An earlier episode we also did on how to draw your pain. That gets into different types of body part pain, particularly back versus leg. Is there nerve involvement and to what degree? So what we want to come out of this episode is for primary care doctors or other physicians to be able to basically, at a glance, quickly look at this algorithm and decide from a conservative perspective, from a more interventive or medication perspective, what can I do? What should I do? And when and should I refer out? And who should I refer out to? So we'll touch on some different, personal experience pieces for me, some different pathologies that you guys will recognize again from earlier episodes. And it will really help if you are a practitioner more effectively and efficiently work through back pain presentations, because one thing Dan and I definitely agree on is that non-specific lower back pain is not an awesome diagnosis for patients. And we'll also do a little bit of myth busting around how much of patients' back pain really resolves. Is it as much as people think? And if not, what should we be doing better, right?
Nice. That is exactly what we're going to do. So for this episode, there's a presentation that goes along with it. So if you want to be able to see the presentation, you'll be able to see the episode on YouTube. So you can go to the YouTube channel and it will be there so you can actually see the algorithm. The algorithm as well, we will put up onto the website, so you'll be able to see it there. So this algorithm has been picked up by the Faculty of Pain Medicine in their Better Pain Management education series that they put out, which is, I'm pretty proud of that actually. That's pretty good.
Yeah.
And it's based on a couple of different things. So there's some Australian guidelines, which aren't really Australian guidelines, and New South Wales guidelines, which is one of our states, that guide people through how to manage pain conservatively. So I've taken those, and it's also based on a paper two of my mentors and business partners wrote, Dave Vivian and Paul Verrills, and they wrote it in 2004 and published it. And so it sort of fleshes out a lot of the interventional side comes out of that paper. And there's an overall algorithm, which I don't have set up to show. I should have set it up to show it now. But anyway, which will put the overall algorithm up on the website so you can see the overall low back pain algorithm that I work through when I'm seeing patients, which is bigger than the one you can see on the screen.
Yeah, this is kind of a piece of that one.
This is a piece. Yeah, it's a piece of it. Let's just move through this. And as Juz says, this is aimed at if you're particularly a primary care physician or a general practitioner and you have limited amount of time to be able to look at where are you within the algorithm, make a decision about whether you're going to manage the patient conservatively or whether you need to move on and actually do further referrals or further investigations. And he basically lays it out into that. Here's the conservative side of things, and on the other side, here is the people that you refer to. We'll also dig down further into the details on how you diagnose each one of these components of pain, but that's not the main aim of this algorithm. The main aim of this algorithm is to guide people how you manage people relatively quickly. All right. If you're watching the YouTube, you can see my disclosures, which, essentially means I own a couple of different practices, some shares in some stem cell companies, and I'm a consultant to Medtronic and Nalu at the moment. None of that impacts on what we're going to talk about today.
Yeah.
No, anyway.
Nice.
Okay, so as I just said, the algorithm itself is split into two components. It's split into, the first set is conservative management. The second component is then more interventional type management. And so when we kick off, the question's going to be what defines whether you are going to manage the patient conservatively. And so there's four major factors that you need to think about here. So the first one is is the patient coping? The second is looking for red flags. The third is whether their pain has been persistent for less than 3 months. So that varies in jurisdictions around the world. So different non-specific lower back pain algorithms have a month before you need to go on and investigate
Where is
it.
that cutoff?
It's 3 months, it's 12 months. As I recollect the New South Wales guidelines, it's 3 months. And then how severe is the pain? And in this setting, it's not severe. So if you're going to be managing the patient conservatively, the patient's coping, they've got no red flags, it's less than 3 months and the pain's not severe. So if we just dive into some of the details on that. So what does coping mean? So coping you can work out in a number of different ways. The recommended way is that you go about, you do an Arebro, which is an outcome measure, or you could look at start back. If you use an Arebro measure, if it's less than 50, then you're at decreased risk of having ongoing pain going forward. I have a different strategy in this setting. So I have the
just ask. Well, it's just like with the neuropathic pain. You can either just ask or
just
if it's
ask approach. So, and my just asking fits into how are you? And so I have a 5-point structure to my how are you. So, and I do this with everybody. So how are you? And people will say, what will happen is people will say, if they're coping very well, say, I'm great, thanks, or I'm well, thanks. How are you? So they have enough capacity to be able to state that they're okay, but also then inquire after my well-being.
You haven't shifted as much to the self-centered survival mode.
No, they're not.
I'm here to tell you how I'm struggling. Yes.
So the next piece, the next step down is I'm great. I'm going really well. Then the next step is I'm good.
Right.
Then the next step down is not good. And then terrible. And so as we're going from I'm great, how are you, down to I'm terrible, I'm pretty much making a judgment on how well the patient's coping during that. Yeah. So if they're not coping, well, that's when I'm going to be making decisions pretty quickly to refer them onto psych services and to support them at that time. So the next part is looking at red flags. So red flags, if you're a patient and you're listening to this, those things that doctors are thinking about are, am I going to kill you if I miss something? So
this is coexisting pathology, Dan, rather than amplifying red flags like emotional status. This is biological coexisting. Investigate if there's...
So but the thing that's really important in this is that I fundamentally think about this stuff all the time.
Yes,
I think
we've talked about this a lot.
The basics to the way I think about patients are ABC, which I don't, so airways, breathing, circulation, which in this sitting doesn't matter when I'm in a clinic because people have walked in. When I was doing more hospital work where you're walking into somebody's room, you want to be able to make sure that they've got an airway, they're breathing and they've got a blood pressure, which is different, obviously, to what you do in the clinic. And then the next question is, does the patient have something that will harm them for the long term or create, significant medium-term issues or even worse, kill them? So the questions there is you're looking for, do they have a history of malignancy? Have they had unexpected weight loss? Have they got history of symptoms consistent with infection? So fevers, shivers, shakes, night sweats. Have they had any significant trauma that might indicate that this is a fracture? Or they've been on medications such as corticosteroids that increase their risk of fracture, or they've got a known history of osteoporosis. There's quite a number of patients, particularly with low back pain, that will come in with insufficiency fractures, particularly of their sacrum, which they hurt like hell. Like people, and it's quite amazing. They sit down, they have no pain. They stand up, it's a 10.
It's excruciating, Yeah,
it's excruciating. It's quite amazing how it presents. Has the patient got neurological symptoms? And in this setting, the neurological symptoms aren't, I've got some pins and needles and numbness down in my legs. It's have they got cauda equina, which is you generally present with numbness through your saddle region of your pelvis, and they will present with things like with incontinence, whether urinary or bowel incontinence. And the other big neurological thing is, have they got progressive neurological symptoms? So someone says, oh yeah, I've had a bit of numbness and now my leg doesn't work. Okay, that's progressive symptoms. It's a red flag. go get it sorted out. And the last thing is, do you think they've got an inflammatory arthropathy? And so where that comes in my questioning, is how long is their pain lasting, particularly in the morning? And so the cutoff for me is 60 minutes. For a number of colleagues, it's greater than 30 minutes. But basically, if you've got pain lasting for prolonged periods in the morning, or stiffness that is worse than the pain. Oh, my main problem is stiffness, not pain. Okay. Then I'm starting to think about inflammatory arthropathies.
Yeah. So don't miss anything major. Is this section.
The stuff that will kill the patient. Okay. That's rule number 1.
Step 1.
Don't kill the patient. We'll talk about my rules one day.
We'll do a
rule. We'll
do rules episode.
Dan's rules of medicine day. Anyway.
Day. A special day. Dan's rule of medicine.
Maybe we'll take a day. There's only 11 rules, so we'll get through it quicker than
it's like an hour, a whole day.
So next question is, is their pain less than 3 months? And if it's greater than 3 months, it's time to sort it out. So that was where you skip out of the conservative management side of things and skip into
investigating, looking further, find and fix, try to diagnose. You should.
Yeah. So there's been some stuff published over a number of years that, if you just go back to the 90s, so Kleineman showed that those in pain for 2 months stay in pain is essentially what they concluded. And Von Korff and their team at the same time published in 1996. And they basically showed that 20% of patients with low back pain recover, 55% go on to have low intensity pain, 15% go on to suffer moderate level pain, and 10% remain significantly disabled. Now, 10% doesn't sound like an enormous percentage, but if you put into context that 80% of the population has back pain in their lifetime, that is a massive number.
It's a very large patient pool.
Yeah. So for patients listening to this, what we get taught in medical school, and every doctor's about to nod their head, is that 90% of patients get better in 6 weeks. This is what we get taught.
I'm going to remain calm. I'm going to remain calm.
Right. Okay. And so the question is, where does that come from? Okay. So where it comes from is from a paper written in 1966 by I think it was a general surgeon working in
a fellow named Delane.
So he did a retrospective review of his clinic notes. Okay, so he looked at 470 patients that had presented with back pain from 1961 to 1965. So if you were to look at that and rate that as level of evidence, it's kind of level...
How good of a scientific study is this?
Level 4 or level 5 evidence. So it's not particularly high. However, he made a number of conclusions. And let's put into a context. Back then, we didn't have these numbers, and what he was working with, he did an amazing job. However, it's not necessarily, it doesn't exactly encompass what might be the truth of the matter. So he went on to make a couple of conclusions. So, and I'll just read them out. So the majority of attacks, and in this case, he's referring to back pain, were of short duration, lasting less than 2 weeks in 62% of cases. A high proportion of patients did have further attacks. 44.6 of those with an index attack had a recurrence within 4 years. And he also quoted that 90% of cases, only symptomatic treatment was needed. So you didn't need to go on.
At times that it's worse,
and his symptomatic treatment was anti-inflammatories and paracetamol. So those have been propagated over many, many years. And
this is where the 90% of back pain
And this is where the 90% of back pain resolves in 6 weeks stuff. So Hardvigsen, which is one of the authors of a Lancet paper in 2018, what they quoted was most people with new episodes of lower back pain recover quickly, which matches Delane's 62% get better in 2 weeks. However, recurrence is common, 44%, in a small portion of people. Recurrence is common, and in a small portion of people, low back pain becomes persistent and disabling. Okay. And this is somehow morphs its way into our education system as 90% of back pain resolves in 6 weeks. Well,
right. And then gets repeated and spread and believed as fact.
So what's the actual numbers? So if you move to 2014, and I don't know how,
so like 55 years later, from the 60s.
Yeah. So I don't know how Lancet missed the guys writing this, missed these studies, but anyway, they did miss them. So artists in 2014, what they did is they did a meta-analysis of 70 randomized controlled trials, 19 cohort studies, and it encompassed 10,783 patients. So we're up from 400.
For 400, I was going to say, yeah. Way larger pool.
And provided 12 months data. Okay, and so what they show is that patients' average pain improved from about a 5 down to 3.5 by 6 weeks. So that's a 1.5 reduction in average pain. And it then sat at about 3 out of 10 out to 52 weeks.
Yes, right. Not resolved.
That doesn't sound resolved. And so if we go back to what we were talking about before, so Kleineman, 1995, concluded those in pain at 2 months stayed in pain at 2 months. And so if you look at the data from Artis et al., that pretty much tracks with what they had stated.
Yeah.
With von Korff, they had in 1996, 20% of patients recover in full, 55% have ongoing low intensity pain. So that's sort of that.
Yeah, better,
that gives you your 2 to 3 out of 10. 15% have moderate levels of pain, and 10% remain significantly disabled. And I think if you look at Artis's diagrams, if you're looking at YouTube, you can see that those numbers pretty much track with what they have found. So
yeah. That sounds a lot better.
So does 90% of pain go away in 6 weeks? No, it doesn't.
No.
20% of pain probably goes away in 6 weeks. And then the other 80% of patients have ongoing low-intensity pain.
Right, not crisis.
And 25% have moderate to significantly disabled.
Right,
so,
which is significant.
Yeah. Let's just ignore it and
it'll go away.
It'll get
it's
better.
like, and this is also where then you have a disconnect between physician reaches end of what they would investigate or even believe is appropriate to. And so then it becomes patient's fault, patient's problem, psych things, right? You then pivot away from investigating and finding what's actually driving it because it's like, it should go away, or you don't have a way to sort of tease it out and kind of try to get more to the root of it. But it's great because it gives context to exactly why this algorithm, and then having, a clearer way to work through it is appropriate, because you can't just chuck it back on the patient.
With the persistence of pain, what's the consequences of that?
Right.
So I'm, in the background looking at a couple of some work cover stuff at the moment. And what do you find? So if you look at return to work after a work claim. Now, bearing in mind that lower back pain is one of the highest causes of workplace injury. So basically the numbers in Australia, if you're off work for 20 days, you've got a 70% chance of getting back to work. If you're off work for 45 days, you've got about a 50% chance of getting back to work. And if you're off work for 70 days, you've got about a 35% chance of getting back to work. So why we wait 3 months based in the guidelines is
very
something beyond me, because the consequences are enormous. And and interestingly, the 35% number doesn't change. So
if you
get
70 days versus wherever,
70 days to to 1 year
Years.
to 2 years, the data basically, you got about a 30%, 35% chance of getting
right. So waiting until 90 days by default puts the patient in a difficult position. It puts the practitioner in a difficult position. And then it's blame and shame the patient. Patient gets continued atrophy, weakness, inhibition. Again, 3 out of 5, 3 out of 10, 4 out of 10. We're not talking the worst types of pain we're talking about on this podcast, but it is enough to create those periods of deconditioning, right? Periods of then sliding back as you deal with older populations, and it could be better avoided, which is I think
anyway, my algorithm says you should wait 3 months because that's what's in the New South Wales guidelines.
Well, but that's the definition of chronic pain, though. Right, regardless of your personal perspective, that's what is accepted as chronic pain is 3 months on, and so before then, you're not looked at through that lens. It's not ideal.
No, it doesn't make sense to me. But anyway, let's keep moving. All right. So here's the next one. So the next myth is you can't diagnose lower back pain. So Harvigston in The Lancet, once again, trotted this one out. For nearly all people with low back pain, nearly all people with low back pain, it is not possible to identify a specific nociceptive cause. Now, the thing that's so amazing about this statement is that it's so accepted within the medical fraternity that you can't diagnose lower back pain that they didn't even bother to reference this. So this is a completely unreferenced statement within...
That's just accepted.
Within quite a large paper with some very big names on it. So where does that come from? So let's go back to Delane once again. He's doing a cracking job, but
killing us.
He's doing a cracking job in 1966.
Yeah.
And so what has he got at hand? What he's got at hand is he's got the ability to take a history, do an examination, and he has some, the ability to do some imaging.
For him, it's largely true.
Low-grade imaging. So
right.
Very difficult. So he concludes that no cause was evident for the back pain attacks, in 79.3% of males and 88.8% of females. And so there you can't diagnose low back pain.
Almost 90%.
So what happens if you step outside that? I think we did a podcast on diagnostic limitations. And,
this is a perfect example of that.
Yeah, and we spoke in relative depth around how things like non-specific lower back pain is a diagnosis of limitation. We know that history is poor at predicting diagnosis. We know that examination findings are poor. We know that imaging, particularly
those are
whether
all true.
It's CT, whether it's MRI, are poor at generating an accurate diagnosis. However,
or a full diagnosis.
That does not mean you can't diagnose lower back pain. And so if you take the next step and you do a diagnostic block, what you will find is there's then 5 major causes of lower back pain. So facet joints, sacroiliac joints, hips, discs, and nerves. So facet joints are the little joints at the back of your spine. And when somebody says, I've got arthritis in my back, what they mean is they've got arthritis in their facet joints. And so facet joint pain accounts for 15 to 40% of lower back pain when you go down and look at the diagnostic block data. Sacroiliac joints are the joints that join your back to your legs, and they account for 10 to 20% of lower back pain. Hip joints, everyone knows what a hip is. So hip joints, 40% of them refer to your bum. So 5 to 10% of back pain arises due to hip joints. Discs, so the intervertebral disc or the cushion that sits between your vertebra, when it starts to degenerate or you've got tears or whatever are going on, it accounts for 16 to 26% of back pain. And nerve root compression, so back pain with leg symptoms, accounts for 12 to 40%. And so that concept that you can't diagnose lower back pain.
And 90% of it, up to.
Is not true. So you just need to take the next step in your diagnostic algorithm.
Yeah. And this is a more appropriate spread of where pain is coming from. Yeah.
Yeah. And I think that as soon as you've got an accurate diagnosis in that setting, what does that provide you? That then changes the way that you manage the patient.
You can treat. Right.
All right.
Back to the algorithm.
Back to the algorithm. So in this setting, we've now gone through, the patient is coping, there's no red flags, it's less than 3 months, and the pain is, not severe. So how do you manage it? So this is the conservative elements of it. So these are the basic conservative elements. How do you move through this stuff?
Yeah, I'm chuckling to myself going, God, I wish I got my hands on people 3 months into their journeys too, instead of like years down the line trying to do the conservative stuff. But yeah, ideally, sooner the better. And from a conservative perspective, there's the self-management piece that the patient is responsible for. And then there's still the conservative bucket of things that the patient still kind of has to outsource and would need more resources for, but we're before pivoting to medications and more invasive treatments. So under the self-management bucket, as far as educate, what comes to mind? Like things around positional challenges. Does sitting make your pain way worse? Obviously, how can you work or be productive in ways that help break up some of the things that exacerbate your pain? Understanding like what this podcast does, how pain works, right? What things make it worse? Even if you're early on, what things might aggravate it? What things might amplify it? Knowing that you can impact your pain even earlier on through mindfulness, distracting, downregulating, right? Some of those more mindfulness related pieces, being able to tease apart even early on, right? What do you control and what do you not, as far as contributing factors, things like we touched on with weakness, inhibition, some of those sensory challenges, and even understanding, like if you're someone like me who has underlying tissue laxity, education around, well, what is hypermobility? Like how does HEDS work and what other things then are really important? Because if you don't understand that, you don't change those pieces. So from an education perspective, that's kind of how I look at it. With reassurance, again, it's feeling like there are things that you can do to combat your pain, combating helplessness, building confidence, right? Whether it's through movement, whether it's through other strategies, realizing that you impact your pain, having different strategies and things that you know that you can go to in different settings, given your capacity, given how badly you're flaring. And I can say for sure for me, right, it's having things that I know I can do without having to outsource from a movement perspective. So specific exercises, specific things that I have in my toolbox give me reassurance that even when it gets bad, there's stuff that I can do to maintain agency. Kind of brings us to staying active, right? Building that underlying stability, having different techniques and strategies to go to, knowing how to progress those things sustainably and given your level of flaring and capacity, so that you can, as best as possible, avoid periods of deconditioning. This is really hard, even for me, because of my work, I sit a ton. So whether it's work stuff, family stuff, right, other context pieces that make it hard to stay active, finding ways to do that is really, really important. Ties right into pacing.
I want to make a comment on the stay active. Within the acute back pain phase, that whole, I just want to lay down in bed and
do
stay
nothing.
in bed and do nothing. Like that is very powerful and it hurts so much.
Right.
Like the data on like just go to bed and do nothing is bad. You do not. That is not the way to go. And so you do want to try and stay as active as possible, which then comes into how you pace yourself. So, Jazz, what's pacing?
Well, pacing, my least and most favorite thing. That's like, so even this ties into the letterbox program, right? Movement too can be more structured or unstructured. And you have to be able to think about it in both ways and be kind of flexible in how you approach it and be aware of your capacity and your context pieces so that you can choose different types of movement that maybe have a different toll depending on how many other stressors you have at that time, which is basically pacing. Pacing is an awareness of how you're organizing and sort of balancing things out and giving yourself built-in recovery time from some of these things that even if they're healthy and important can take a toll, right? Movement's really good, but it's hard. So you have to be able to support that and recover from it to even pace it properly. And a lot of times people, I mean, we talked about this too, people like to blame movement itself for when they blow up, but often it's a pacing, like surrounding issue, capacity, stress, or problem rather than the movement itself. So don't demonize the movement, right? Tweak some of the other variables so you can do it more sustainably. If you flare, back off, go 1 letterbox, not 3 letterboxes. And that's why movement falls off very early for me too, when I have capacity issues, because it takes a toll. And it's one of the things I cut early, like to survive, but then it creates huge challenges and increased pain. And then you got to go listen to the flare episode. Yeah. So that's, it's horrible.
Yeah. Is that whole thing with pacing? Is it what happens?
It's a never ending thing.
People start to feel better and then they go and do too much and they flare themselves up. And
Dan's now known me for long enough to see that.
Yeah, I've seen that now. But the thing that, like, for me, I always try and reframe that, you felt good enough to go and do something, which is great, which means you're actually getting better. Right. It's just you did a bit too much. That's okay.
Right, yeah.
Just let's get it under control again, and then we build up slowly and move through that rather than, like, try and, like, hurdle it.
Right.
So,
yeah. And even gaining confidence, experiencing that and going through that and knowing, I talk about this with clients all the time, but it's like this perpetual shuffle of 3 steps forward, 1 step back, 2 steps forward, 3 steps back, 2 steps forward, 5 forward. So it's like you are moving in the right direction, but it's not this nice, neat, beautiful escalator of progress. That's how I thought life worked when I was younger, right? You just start here, it just goes like this. No, it's not. So that's very reflective in pacing. And then all of this ties into goal setting, which is another really, really good episode to reference from earlier on, where you're trying to change these things. You're trying to, care about these habits. You have to connect the behavior, the habit, to the outcome or the thing that you want to be able to achieve. So if it's play with your kids, be able to get back to work, not fight with your spouse, have more independence, strength, avoiding these weakness, spasm, atrophy that then lead into hopelessness, desperation, catastrophizing cycles is key. And it is even better if you can learn this, like I said, very early on than years down the road, because then as soon as we get to Dan's treatments and intervention, they have the best, the best ability to work and be most effective. So work on these things in parallel, early and often, would be my 2 cents. Because you can't outsource or chase things with medications and treatments that you actually have to address as a patient. I can Botox and trigger point and, procedure, whatever, out of my back. The issue is underlying instability. And yes, some procedures help with that specifically, which is a separate conversation, but you can't outsource some of the pieces that you have to be able to improve and tend to from a stability, strength, atrophy perspective. And then you maintain more agency as you go long-term.
There's the other rehab piece in there. And I think
the outsourced rehab piece.
Yeah. Yes. As you're the GP, if you're trying to make, or the primary care practitioner, and you're trying to make a decision about what you do, absolutely engage with your physical therapist, your physiotherapist, your exercise physiologist as a means of helping the patient structure how they go about doing their rehab and doing that early. But certainly outside of, the acute scenario or the acute.
And especially outside the acute, like as you do run into, unfortunately, the more chronic, more ends up on the patient. But that is the part from a rehab perspective where, yes, help them learn, right? Most patients don't have a movement background or understand these concepts. And that's the part where then they can build confidence. And then those practitioners can shift a little bit more onto them over time, but hook them up, help them out early.
Yeah. So as a doctor, someone's going to be coming to you, and they're not only coming to you to tell them to, stay active and pace and set some goals. They're going to want you to help you coming in to,
what is this
to get
crap?
you to help them with, what is that? They're getting you to come in and ask for some analgesia, basically. So analgesic options, and although I'm not going to dive into them in detail, there's the usual things. So paracetamol, although if you look at the data, paracetamol is probably mostly placebo. However, it's a mostly safe placebo. So if that gets it across the line, that's fine. Anti-inflammatories. So anti-inflammatories have multiple issues across the board, including gastroenteritis. Whoa, you okay? Or are you like...
Yeah. No, am I okay, but not okay? I'm fine.
Okay.
The sweating's ticking up.
Okay. All right. I was noticing you were getting shiny, which means we better...
Just I'm either getting excited or pain's creeping up. You never know with me.
I generally use celecoxib in this setting as it has the least kidney issues, the least cardiovascular issues, and the gastrointestinal issues you can cover with a proton pump inhibitor, which is what I generally provide with patients. One thing that I hadn't done much until recently was the use of 5% lignocaine patches. There's some good data
really?
on that. Application of those during the acute period can significantly decrease patients' pain.
Yeah, and that's one too that even if it doesn't have great upside or doesn't work for someone, it has like no downside. So non-invasive, try it. And it's fine.
Yeah, and in Australia, that you can get some
prescription strength.
The patches are big, like 10
by
15. Yeah, 10 by 15 centimeters, and
I've tried them for low back.
Yeah, and you can use them for lower back pain. And then after that, you're looking at how you then alter the neuropathic component to pain. So with any part of your system, basically your paracetamols and your anti-inflammatories are dealing with nociceptive pain or body part pain. And then you've got the nerve component to that, whether that nerve component just be amplifying the pain or it actually be nerve injury, which is causing neuropathic pain. And then you're looking at things called tricyclic antidepressants. You look at serotonin and noradrenaline reuptake inhibitors. So they are, from brand-wise, the tricyclic antidepressants. The most common one is known as NDEP or amitriptyline. For the serotonin and noradrenaline reuptake inhibitors, the most common one is generically is duloxetine. From a brand name, they're generally Cymbalta. As a note for pain, I think it's off-label in Australia. So just need to know.
Yeah. And these are drugs we've covered too in the NNT episode as far as like efficacy and side effect, right? Upside, downside conversations. And
then the last piece is the anticonvulsants in this setting. So that's pregabalin and gabapentin. So for that stuff, pregabalin isn't effective for sciatica. So that's the electric shock that goes down the back of your leg. So if there's one thing that I can get like GPs not to do, don't prescribe pregabalin for sciatica, because the data is pretty good that it does not work for it. So anyway, that's just an aside. If you are, I think I've mentioned this in previous podcasts, if I'm trying to work out what medications I'm going to use in this setting, and we moved into the anti-neuropathic type medications, if the patient has got significant troubles with sleep, I'll use a tricyclic antidepressant. If the patient,
kill two birds with one stone.
Yeah, if the patient cries on me, so that there's this component of depression, I'll use duloxetine. And if the patient's already on an antidepressant, well, then I'll go into the anticonvulsants and I'll use gabapentin to start off in that setting. Yeah. But everyone can move through that as they feel comfortable. So
that's a good overview.
So the next piece there is then review. So how often do you want to review the patient? You want to review them at 2, 6, and 12 weeks after you've had your acute flare. If they're improved, great, just keep going, more
Stay
of the
course.
Conservative stuff.
Right.
If they're not improved, move on to the next part of the algorithm. So the next part of the algorithm is looking at essentially defining what's going on for the patient. And so it also encompasses those patients that don't tick the box at the start. So the patient that is not coping, the patient that has got a red flag,
over
or the patient whose pain
over
is severe and you need to really do something about it. So with not coping, a Rebro less greater than 50. I can't remember.
Clinical judgment or a Rebro scale.
Or not coping based on the how you're going.
Or Dan's 5-point.
The Dan 5-point,
it's a very strong marketing.
Yeah.
Trademarked,
yeah. So, and then next piece is then, do they have any red flags? So if they have red flags in that setting, it's organize appropriate imaging, whether that be an MRI or CT, get a series of bloods and make an urgent referral at that point. So that essentially amounts to getting on the phone, talking to your friends and saying, I need you to sort this out for me, please.
For the yellow not coping one, it just reminded me too, as a patient, I have patients too who have talked to me about being scared or apprehensive to talk about how depressed they are, or how much they're struggling from a psych perspective when they go in to see their physician. And that's not helpful, because you can't then get help and treat, and just like we just talked about, outsource and refer that part so that you can bring the pain down and better find the underlying things. So you should have a relationship with your physician where you feel comfortable talking about those things. But if you don't, then it makes it even harder to get to the root, more underlying things, and fear of being blamed can keep people from being as open about those things as you would hope they could be, because it does affect treatment and it's not helpful.
Yeah, and I think that the important thing is here that if you do have severe anxiety or depression or whatever, it doesn't cause the pain.
Too, right?
Number one, it makes you normal. But number two, it doesn't cause the pain, it amplifies the pain.
Right.
So we are not...
Doesn't invalidate the reason you're there. Right.
No. And so, the 5 major causes of lower back pain are
don't
facet
include
joint, sacroiliac joint, hips, disc, nerves. Like depression, anxiety is not on that list.
Right.
But depression and anxiety are amplifiers of those pains.
Yes.
Of those 5 causes. And it's important that if we can effectively manage them, we can then downregulate the pain arising from those 5 causes.
Exactly.
And in some cases, it might be that we can downregulate that stuff enough so we don't have to treat one of the 5 causes, whatever it's
And in some cases,
whatever.
how you downregulate that can even be procedural, like with stellate ganglion blocks we touched on, I think, for patients that present with severe anxiety alongside complex pain. So if you don't open up about that, you could lose treatment options potentially.
Yeah. Okay. So we then move to diagnosing. And so I'll go through this a couple of times, but basically the way you work out lower back pain is you want to work out first. Number 1, is the pain worse in your leg or in your back? If it's in your leg, you start at nerves first, okay? If it's in the back, you split the back up. So if it's above the belt line, you look at facet joints and discs. It's below your belt line, you start at sacroiliac joints and hips. That is the way you work through lower back pain, okay? Yeah. And so in this setting within the algorithm, pain greater in leg than back, so start at nerve first. So in that setting, the first step, over and above, not forgetting to give the patient analgesia as you investigate them, is get a CT or MRI. My preference is always an MRI, and looking for what nerve root is involved in the situation. Now, one of the interesting things about if you're going to decide to help settle the patient's pain with an intervention, and in this setting, what you're going to do is you're going to do an epidural. They're commonly called nerve root injections as well, is that your nerve roots, the lower back, have a pretty definitive areas that they cause pain. So if the patient's pain is going to their big toe or commonly their heel, it's going to be L5. If it goes to their little toe or the sole of their foot, it's S1. If it goes to their shin, it's L4. If it goes to the medial or the inside part aspect of their knee, it is L3. If it's upper and mid-thigh, if it's mid-thigh, it'll be L2 and groin will be L1. If you've got pain going to the lateral aspect of the calf, that's where L5 and S1 overlap. And if everything hurts, you can just do what's called a caudal epidural. So how I work this out is not necessarily based on what the MRI says. I work it out based on where the patient's pain diagram
so this is where draw your pain.
And this is where drawing the patient, getting the patient to draw their pain. L4 is a great one because patients will draw their pain and they come down, they just draw it over their shin. That doesn't go into their foot and you go, L4, great, let's go.
Yeah, we have pictures too, I think, on the website of these different referring patterns from the Draw Your Pain episode. So check those out.
Some in this talk too. So if you're going to make a decision, I think make the decision clinically and use the MRI or the CT as evidence to support your decision.
Right, supplementary info.
Yes. Now, if you get a scan and, L3 looks like it's being there's contact with the L3 nerve root and there's nothing touching S1, but it's all little toe outside of the leg and sole of the foot. I just treat S1 because the imaging doesn't match the presentation. And
go with the presentation.
I treat the presentation. You need to get comfortable with doing that. But I think that the risks of epidural, although present, are still relatively low and the benefits can be substantial.
Well, and again, there are also risks of just persistent, ongoing, unaddressed, undiagnosed pain. So that too becomes like a...
And in this setting, so the next step after this is then what happens is then you're going to make a decision to make a referral to the surgeon, at which point in time they're hopefully going to sort it out. And so if like most places, certainly in Australia, if it's an uninsured patient and they're moving into the public sector, the wait time for review on a nerve root compression in the public sector is going to be minimum 12 months. And so where you can treat them,
Canada.
if you can treat them acutely with an epidural, well, most people are going to be pretty thankful.
Yeah.
So next step is back pain is worse than leg pain. And the first decision you're going to want to ask is, do I need to send them to the surgeons?
This is when to specifically surgeon referral.
Basically, when you've got back pain that's more dominant than leg pain, you are looking at, have they got progressive neurological symptoms? Yes. Off to the surgeon. Have you got cauda equina, so urinary fecal incontinence, numbness through their saddle? Yes, send them off to the surgeon. Leg pain greater than back pain? Yes, you're going to get a surgical opinion as part of you working them up and treating them. Have they got neurogenic claudication? So neurogenic claudication is a condition where you have what's called central canal stenosis. So that's where the spinal canal down low, so not over the spinal cord, but over where all the nerve roots are, is becoming narrowed. And how it presents is patients will walk and they'll get this broad, achy pain that extends across their lower back to their buttocks and then across the back of their thighs. And they'll walk 100 meters, they get the pain, it stops, they go away. They walk another 100 meters, they stop, they sit down, pain goes away. They walk another 100 meters.
It's like a shuffle.
So it's very, very repetitive, and it's pretty much 100 meters, or it's 50 meters, or it's
on, off,
or it's 300 meters. But it's it's
whatever
very
the
much,
pace of that is, or that interval. It's repetitive, right?
Yeah. And the other thing is that patients a lot of the time will use, I feel better when I lean on a trolley when I do the shopping. And so
or the cart, right.
Yeah, a cart.
Like grannies pushing their cart. Yeah, sorry, don't speak in Australian, Dan.
Sorry.
Yeah.
So we call it a trolley. So cart if you're in America, and a trolley if you're in Australia.
Or a cart if you're in Australia.
Yeah, I don't even know what do they call it in Europe? I don't know.
They don't use them. You just carry stuff with your bare hands. In the motherland, we don't use carts, wheelbarrows.
And if they've had previous surgery, so I think that in those sort of settings, you want to think about moving towards a surgical review. The question after that is moving on to, okay, so now what we've got is you've decided that they don't need to go see the surgeon, but they've got back pain greater than leg pain. So that's a no. Now we're at, what are the causes of back pain? So it's facet joints, sacroiliac joints, hips, discs, nerves. And so how do you work it out? So this is the back pain rules of thumb. So as I've sort of already described, if your leg pain's greater than the back pain, start at nerve. If your back pain's greater than your leg pain, start at back. And so if the pain's above the belt line, where you start is facets and discs. If it's below your belt line, you stay at sacroiliac joints and hips. And particularly above the belt line, if the pain is centralized, you're probably going to start at disc. And if the pain is unilateral, you're going to start at facet. So
and this is where some of these differentiating questions are really helpful to avoid procedures possibly that you can, right? Like I did, like I said, blocks, trigger points, medial branch blocks, 6 at a time when I was highly, highly sensitized in my lumbar area. And if through this type and this line of questioning, we could have deduced, you have SI joint instability, et cetera, rather than it wasn't wrong to try to diagnose it using this approach, but it could be avoided if you had a different way to look at it rather than solely relying on that. So it's both. And it's an interesting, conversation.
These are rules of thumb. These are rules of thumb. So the biggest problem with lower back pain, and I do have this diagnosed. I do have that. I'll go on to it. Okay.
And so many things, are in hindsight 2020. But when you're also working through it, it's not as clear as it is at this point.
So, we go through, for those who have looked at how to draw your pain, you basically ask the patient to draw the pain. So if it's achy, get them to do a scribble. If it's sharp, do a lightning bolt. If you've got pins and needles, do some dots. And if they've got numbness, get them to circle the pain. And so here on the left, you can see this is the area that different structures refer pain to. And on the right, if you look in the YouTube, you can see what patients commonly draw. So
and again, commonly, like most.
Commonly, not all the time, but commonly draw. So now the thing that's really important about this is, so you can look at the diagrams that give you this is where, these 5 main causes of lower back pain send their pain, which is great. But I think mainly the most important thing is they actually just all overlap.
Right, which makes it tricky.
Which makes it tricky. And so once again, just thinking this as a guide, it's not necessarily this is where it is, draw it here, this is what it is. No, it doesn't work that way.
Yeah, although, you can have SIJ and hip pain, or right, something again.
You can, or SIJ and facet. So
super fun.
So moving on. So the other thing I then ask the patient to do, so I'll get them to draw their pain first, and then we go through the process of asking them to point at their pain. And so what that allows you to do is for patients that struggle with body position sense and can't really pick, where on the diagram they're actually pointing rather than...
Your brain
you then get them to point at it, and then you as a clinician, you correct that. You correct, okay, that's a bit lower, that's a bit higher, and it gets you a bit of an idea. And so
it's like correct and confirm.
Yeah, pretty much. And so different areas of pain patient will point at different things. So interestingly, the main ones with this is that if it's above their belt line, particularly in its facet joint, they'll be pointing unilateral. They commonly use one finger or they'll use two fingers. When it's sacroiliac joint, you'll be asking them, I ask the question, point to your pain with one finger. And it's a bit of a tricky question because patients that can point to it with one finger do, and that's called Fontaine's sign. And Fontaine's sign is an indication that they have sacroiliac joint pain. And those who can't, they'll point more broadly and they'll show that, my pain extends more broadly across my sacroiliac joints
iliac crest,
and glutes. And so that's more consistent with sacroiliac joint dysfunction.
Like instability versus injury almost, would you?
Well, instability versus osteoarthritis.
Okay,
so
a specific
injury
spot,
can cause, so if you can point in one spot, it's probably sacroiliac joint osteoarthritis.
Versus instability
versus
/dysfunction.
Instability, where what people are pointing at is all the muscle dysfunction around it as they're trying to hold themselves together.
So I always feel like such a jerk too when I go into an appointment. Where does it hurt? And I'm like, here. I'm like, I know that's not helpful, but it is helpful because that's exactly how it presents, right? But that's where I'm always like, that's why.
And with sacroiliac joint dysfunction, it moves from side to side. So patients will go, some days it's on the left, sometimes it's on the right.
How you shift, you favor,
And the reason for that, if you think about your pelvis is kind of like a hula hoop. So if you grab the hula hoop and you twist the hula hoop, you then load one side. If you twist it in the other direction, you load the opposite side. And so that's why patients' pain will go from one side to the other because their pelvis is moving. And it becomes an easy way of it becoming one of your diagnostic criteria. My pain moves from side to side. I'm already starting to think this is sacroiliac joint.
Right.
Because facet joint pain that's coming from a right-sided L4-5 facet does not go side to side. It's right side. It stays right side. So,
and it's broader. It's all the spasming that you're feeling rather than the underlying SIJ even by then.
So facet joint pain, and I think we can just run through these. So facet joint pain will give you pain above your belt line. It's an ache, sharp, dull pain. So it's nociceptive in nature. It tends to be tennis ballish in size. And it'll lateralize left or right unless they've got bilateral osteoarthritis. It does radiate down their legs. So it will radiate all the way down the back of their legs. That is not sciatica. Okay? That is somatic referred pain, not sciatica. So examination-wise, they have pain on extension, pain on quadrant test, and pain when you push over the facets, which, when you scan them, you commonly will find arthropathy on MRI and CT, but it is so common, it's not particularly useful. You can get a SPECT CT, which may help identify which facet is involved. And so that's a nuclear medicine scan where what you do is you get an injection and it shows bone, goes to areas of bone turnover.
We did that with CRPS.
And that is useful.
Yeah, I didn't think of that in this setting.
Yeah, it's only 70% accurate. So just because a facet joint lights up doesn't mean it hurts, unfortunately.
Or that's the reason why.
When you go on to do a diagnostic block, you do a thing called a medial branch block. So medial branch blocks, you're basically looking for greater than 50% pain relief on two separate blocks, which gives you a 60% chance that is what's causing the pain. If you've got 80 to 100% decrease in pain, it increases your likelihood that's about 90% likelihood that's where the pain is coming from. If you might notice, I didn't say facet joint injection in that setting. Facet joint injections are interestingly poorly diagnostic. And it generally is because of the way they get done. So a facet joint itself has a volume of about zero point 0.2 to zero point 0.8 of a mil. So it's tiny.
Really small.
And to be honest, when you're doing the injection,
you can only inject like so much.
You can only put in a little bit. And the other thing is when you're doing the injection, the space you're trying to get into commonly is smaller than the width of the needle. So it gets like they're not easy injections to do.
You're literally, it's like a needle in a haystack. You're literally.
Yeah, you can do them, but they're difficult to do. Now, what happens is that if you look at if you've ever had a facet joint injection and you look at the report, particularly in radiology groups, they'll do a facet joint injection. They'll say, injected 2 mils of local anesthetic and 2 mils of dexamethasone or whatever they use, or cortisone. So what you've done is you've injected 4 mils of fluid into something that takes 0.2 to 0.8.
Tiny.
And so it's
just goes in the surrounding area
everywhere. And so it doesn't just block the facet, it blocks facets, nerves. If you're doing 5-1 facet, it blocks sacroiliac joints. So it just blocks everything. So the diagnostic value of a facet joint injection,
even if you get a good result, you can't even narrow down. Was it?
You don't know why you got a good result. You know, just because the cortisone worked. So or the local anesthetic blocked the thing that was hurting. So it's not particularly useful. What you do with a medial branch block is you use 0.3 of a mil of local anesthetic over the little branch of the nerve that supplies the joints. And it's by using a very small amount of local anesthetic that means you can target
at least you're targeting
actually causing the pain.
Right. Otherwise, why do the diagnose? It's not a diagnostic block. It's just a block.
I had a patient come in the other day with a facet joint injection. The technique was 5 mils of local anesthetic subcutaneously, so underneath the skin.
Really?
And then a couple of mils of local and cortisone into the facet. I was like, okay, we probably need to do this again. Did your pain go away? She says, yeah, it was great. It's blocked everything.
Best procedure. Blocked everything.
Yeah. Anyway, moving on. So disc pain generally will centralize. So it's generally in the middle of the back. It's a dull ache. So it gives you 2 types of pain. A disc will give you a dull ache and it gives you intermittent sharp pain. The dull ache probably comes from the disc itself. The intermittent sharp pain comes from the bone on either side of the disc. So they're called vertebral end plates. No. It's probably actually the end plate itself.
Just the okay.
Yeah, so it is probably bony pain. Yeah, and so that
true bony pain. Yeah.
Yeah, so that intermittent sharp pain that stops people in their tracks. So that is what I'm looking for when I'm looking to see whether they've got vertebrogenic pain as part of their disc-related pain. And so that's probably coming from the vertebra on either side. Interestingly, you can treat that with a procedure called basivertebral nerve ablation, which is we should do an entire podcast on it, but it's a fantastic treatment for treating that intermittent sharp pain that stops you in your tracks. And what's really interesting about that is that just people try to move and they get scared to move. So they come in, they're scared to sit down, they're scared to move because this pain just comes on bang out of nowhere.
0 to 60.
And they stop.
Yeah.
And so guess what? They can't do any rehab because they get all this sharp stuff. So it's
and you reinforce the fear, like you're saying, and
So then all the fear and all that sort of stuff goes on. So basivertebral nerve ablation, which there's great data on now, is a great procedure for that. But it doesn't treat the deep ache, which is really interesting in my experience.
Yeah.
Others will say different. But in my experience, I can't treat the deep ache with the basivertebral nerve ablation. I think that comes from the disc itself. It makes it
but it's like what pieces of the pain are you treating with what intervention?
So from an examination perspective, it's difficult to actually, examine disc-related pain. I think that for me, it's the absence of signs. So you can push on someone, doesn't hurt.
Right.
Doesn't hurt too much and they go this way. No. Yeah. It's a lot of no's.
Which is really frustrating as a patient. Yeah.
Nope. It's going to be disc. And so there is a test called the posterior instability test that does give some indication that it could be disc-related pain. When you go onto MRI, as with everything, MRIs have limited diagnostic value when it links directly to back pain. However, if you've got a thing called a modic change, so modic change is where the bone around the disc has been stressed. So the disc itself is a shock absorber. When you lose the shock absorption, what happens? Same as in the car. Everything else around the shockers start to break down. So in this case, and so what that looks like on an MRI, and you're looking at a vertebra, is it looks like a type 1 or type 2 motor changes. And when that's matched with the intermittent sharp pain, I'm like, yeah, let's go.
Yeah.
So that's of diagnostic value. A thing called an annular tear, which presents as a high intensity zone. So the annulus is the onion layers of the disc, and a disc is kind of shifting between my food analogies, but it is more like a jam donut or jelly donut.
Oh, onions with donuts? Really, Dan? You had to...
Yeah, anyway. So when you get a tear through the outer part of the dough, that is called an annular tear, and it presents as a high intensity zone. So that is also of some predictive value within the MRI. Jazz is in Struggle Town.
Back to sitting.
Yeah.
I stand so long. Don't worry, I'm okay.
It's like, come on, Dan, you're talking too much. Diagnostic blocks. In this setting, I will work through a process of seeing that the patient has negative medial branch blocks, negative sacroiliac joint injections, sometimes negative hip injections.
Not this.
So you're ticking not this, because all these things overlap so much, and because those things are much more easily treatable. And because our imaging findings aren't super useful. So if I'm dealing with the deep ache of a disc pain, I'll exclude the other causes of the deep ache before I get down to it. And the last thing is looking at low pressure provocation discography. And so this is something we don't do that often anymore. There's controversy over whether it makes the discs worse or whether it makes the disc better, whether it doesn't make any difference at all. When you do it, what you're doing is you're placing a needle down into the disc, you're doing an injection under pressure, and you're seeing if you're able to reproduce the patient's normal pain. And there's a whole stack of criteria to be able to do that in a reliable fashion, so that it's pain's greater than 7 out of 10. The pain's in the same distribution as the patient's normal pain. You've put in a small amount of pressure, not tons. Surprise, surprise. If you want to lean on any pressure device, you can make everything hurt. And you have to have a negative control disc, which basically means you do one disc plus the disc above to show that the disc above is negative. So they're difficult to do.
Multiple variables
involved. I think that in many ways, if you're going towards surgery, particularly if you're doing back pain, if you're doing back surgery for back pain,
then
it's worth discography is worth it, particularly if it's positive.
Right. Given the context, what's the upside, downside?
Yeah. If you're not planning on going forward with back surgery, I think you need to, the usefulness is you have to sort of balance it out. So... All right, sacroiliac joints. Look, we'll do a whole. We'll do a whole. Yeah. We should pull out the sacroiliac joint algorithm at some time.
And we'll just intro it because it's such a big deal for the hypermobile
so sacroiliac joints gives you pain below your belt line. You get pain that arises due to three main things. So it'll be inflammatory disorders, osteoarthritis, and joint instability, basically. So they give you pain it arises from over the sacroiliac joint and will radiate down the legs. So 100% of patients will get buttock pain, 50% get thigh pain, 25% get lateral calf pain, and 12.5% patients get lateral foot pain. It's in an S1 distribution, so it's the differential for S1 nerve root compression. And patients tend to have pain on sitting, going from sit to stand, rolling over in bed. If the joint is unstable, particularly that rolling over in bed will cause pain. When they draw their pain, they draw it much broader, like Juz was describing before. And they tend to have pain when they're really unstable. When they've got pain going up and down stairs, it's worse going down. And interestingly, they feel better when they cross their legs. So what they're doing when they cross their legs is they are squeezing their pelvis together. So it's called forced closure. Yeah. And that helps settle down their pain. Although it's not on my diagnostic criteria list, if you have the patient sitting in front of you and they are sitting on one buttock, so they go,
you'll shift.
They sit on one buttock while they're sitting in front of you, they're offloading that sacroiliac joint. It's probably going to be SIJ. So you can think about it along those lines.
It's like a sneaky offload even.
Yeah. So the diagnostic criteria in this is to go down the track of doing a sacroiliac joint injection. Interestingly, the data around SIJ injections is not awesome.
Yeah.
And the way I was taught to do them and the way I still do them is that we inject the joint itself, but also the ligament that's stabilizing the joint. So the dorsal interosseous ligament, because the dorsal interosseous ligament causes a large amount of pain associated with SIJ pain. And so it's...
it's not just the spasming that hurts. That's just the output, right?
Talking to the experts on SIJ injections, they don't inject the DIL, the dorsal interosseous ligament. So, when I was speaking to them, I was like, huh? What? Hang on, that's what
they only do the SIJ.
They just do the joint. And so I think that it's not as predictive as if you do both. So, but I'm pretty sure Bruce Mitchell published on this at some point in time. If I can pull the paper out from somewhere, I was talking to him about it recently. Yeah. They were able to pull out relative amounts of pain coming from each one. So,
is it also maybe unhelpful? Yeah, because you're injecting just the joint, and so much of the pathology with these is not just where the SIJ itself is, as far as where you have pain symptoms. Is that part of why you think?
No, look, I'm being absolutely truthful in that when I was talking to one of the experts on SIJs, and they were telling me how they just do the joint. It was the first time I ever heard of just doing the joint. It's kind of just because that's how I was taught. I was taught, I was taught, I grew up in a clinic called Metro Pain Group. I still work there, and the way I was taught to do it is you do joint DIL.
Yeah, it's so interesting. And the reason I ask is because it's probably the only procedure that I haven't done that would be even remotely appropriate. And it's for the literal thing that I actually have wrong with me. But we managed to diagnose it at this point where we know what it is without doing that diagnostically, because I was just so sensitized that doing an SIJ injection at that time was like, I don't think it's worth it. But
yeah, thank God in Australia you can be asleep to do diagnostic injections.
Here. So yeah, we'll dive into this more separately because it is such an interesting underlying piece and then driver of some of these more complex populations often, especially when you have underlying tissue laxity, right? With pregnancy, those things are spreading because of hormone changes. With us, it's not quite that, but similar output. And then if you have pubic symphysis dysfunction on top of it, it can create a real loosey-goosey situation, front, back, tipped, mutated, and then the SI joint belt can be more aggravating even because we've talked about this a lot, it just kind of smushes everything and gets you more impacted versus sometimes you can put it on and it's like, what a difference. And then when I take it off, I'm like Bambi. It's like veal meat. That's how it feels. Like I feel like a baby
You're like
deer.
Bambi. Veal meat. Oh my God. Okay, I have not.
That's it.
Okay, I'm not. All right.
If you could just do Prolo, Prolo, you'd feel it go right through.
Do you feel like Bambi when you take your belt off? Okay, I'm not going there. I'm not gonna be putting that one into the history.
We're not adding that in the assessment?
Not I'm gonna add that into my history.
Oh my God. I think it's a very positive finding that is always true. It's true.
Okay, moving on. So SIJ instability. Anyway, we've just waxed lyrical about that. So hips, when patients draw hips, most commonly they'll draw hip pain, and it starts at the groin and goes down.
And this is even broader than SIJ.
It's really broad.
Thing. Yeah.
It tends to be anterior, although I think 40% of patients hip pain will refer to their buttock. They get pain on sitting. They get pain on crossing their legs. They get pain on getting in and out of the car, and they get pain on putting on their shoes. And I think those symptoms are pretty. Yeah,
that's different than solid. Sit, stand, walk, roll over in bed. These are specific. Yeah.
And I think that when you're asking those questions, you actually have to ask, does it hurt when you cross your legs? And they'll say yes. And the question is where? In your back or your groin? Oh, it hurts in my groin. Okay, now I'm going towards hip. They tend to work with the limp. Interestingly, I think that you can pick a lot of hip joint pains who they just stand up in the waiting room, and they'll have decreased internal, external rotation and positive theta, so flexion, adduction, and internal rotation test. Imaging findings for this, you just go down the track of doing an X-ray, pretty standard. And you can do diagnostic blocks for them. I think I do them sometimes if I'm umming and ahhing, but it's not necessarily necessary. Okay, so
Nice.
that takes us through
5 major causes
to the end. Yeah. So I suppose if we wrap this up in summary, what are you looking at? You have the patient that presents with onset of lower back pain. You want to know whether they are coping, there's any red flags, it's less than 3 months, and the pain's not grossly out of control. If that's the case, you take them through a conservative management pathway where you've got your aspects of self-management, which is reassurance, exercise, pacing, goal setting, staying active, and then tying them in after that initial period with rehab to get them going again. From an analgesia perspective, you've got paracetamol, NSAIDs, tricyclic antidepressants, SNRIs, and the anticonvulsant versions. And so that really gives you the starting point of any management for lower back pain. Review them on a regular basis, 2, 6, 12 weeks, and keep moving. If it sits outside that, you're going to manage the patient that's not coping with psych. If you're with your red flags, you're going to do the red flag stuff, and everybody who's listening to this knows how to do the red flag stuff. And then the question is the pain leg or back? If it's in their leg, start at nerve. If it's in the back, split their back up. If it's above the belt line, think about facets and discs. If it's below the belt line, think about sacroiliac joints and hips. And within that just gives you appropriate referrals that you can make straight off the back. And it makes it relatively quick to move through looking after the patient that presents in your rooms. Yeah. So there you go.
Easy enough.
5-minute back pain.
5 minute, 5 minute back pain.
Presented in, how long have we been going?
We'll see what Morgan edits it down to. An hour and 22 minutes.
Presented in an hour and 22 minutes.
We appreciate you listening. Any final thoughts, Dan?
No, look, if you've got any questions, reach out to us.
We'll continue propagating more and more information onto the website, also sort of retroactively going back through previous episodes. So keep an eye out for that as we start to build out the resources section of that and provide more written education, right? Other ways for you to integrate, understand, and apply some of this rather than just from an auditory listening perspective, because we know we all have different learning styles and personality types too. So yeah, we look forward to being able to expand on some episodes. And if you haven't signed up for our official newsletter yet, do that. Go to www.iniyh.com so that you get that free resource as well that we'll start sending out after every episode ongoing now. All right.
And for clinicians, as we're moving forward, we'll be making this worth some CPD points, which is always useful for everybody. So we won't kick it off immediately after this episode, but going forward, we will have CPD points available, and that won't be too far away. So
good stuff.
Very exciting.
Awesome.
All right.
Thanks so much, guys. We'll see you next time. Take care.
Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not a consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.